morning to this seminar. Please let me introduce Paul Milligan, just there. Paul Milligan is a biostatistician at the Department of Infectious Disease Epidemiology at the London School of Tropical Medicine, IT and Tropical Medicine. Before that, he worked at the Liverpool School of Tropical Medicine and also in the MRC laboratories in the Gambia. His expertise field includes clinical and interventional trials. Actually, he's working on chemoprevention, seasonal chemoprevention of malaria. Please, Paul, thank you for coming.
Thank you very much. So thanks very much for inviting me to give this talk. So I'm going to talk about seasonal malaria chemoprevention, which is it's a new strategy for malaria control in children, and it was recommended early last year by the WHO as a new policy, and so they're now recommending that children that are living in areas where malaria is very seasonal should be treated with effective anti-malarial drugs once a month in the transmission season to prevent malaria. So it's always interesting to know how these new policies are decided, and we've been involved in this process for about the last 10 or 12 years, and we've seen what the questions have come from the policymakers and how the researchers have done studies to address that. So what I want to try to do is explain a little bit about what kind of evidence was needed for this new policy to be decided. So that's what I'll cover in the talk. The research that's led up to this policy recommendation, and what kind of questions the policymakers asked of the researchers and how the researchers addressed those. And then we'll give a bit of an update on the implementation of SMC, and then some comments on what the opportunities for research now in areas where this intervention is being introduced. So, just to explain what this involves. Seasonal malaria chemoprevention, it's the administration of an effective anti-malarial to children at intervals during the transmission season to prevent malaria. The drugs that are currently recommended are two old drugs that have been around for a long time that haven't been used in this way before. So it's using old tools for a new purpose. And these are sulfadoxine, pyrimethamine, and amidaquine. And if you treat a child with these drugs with a therapeutic dose, then it gives them a high level of protection. This is the protective efficacy over time. So for about 4 weeks, they have a very high level of protection. And so the idea is that you should treat every child once a month during the main transmission period. And it's suitable for areas where malaria is very seasonal, because the malaria problem, the severe disease is mainly in young children, and it's mainly in a few months each year. So by these kind of campaigns of treating a section of the population just a part of the year, you can have a major impact on the overall malaria burden. But it does mean that there needs to be monthly contact with the health workers to administer. So the use of drugs for preventing malaria is not new, of course. And so quinine was used from the 1850s, and it wouldn't really have been possible for Europeans to colonize Africa without quinine. Chloroquinized salt was used in the 1950s in South America. They treated the salt, and if you took 10 grams of salt in your daily diet, you would get a prophylactic dose of chloroquine. And that was used very widely in the 1950s in Brazil and other places in South America. Chloroquinization was used in many countries in West Africa and also in Madagascar in the 1960s and 70s, where children under 14 were put on weekly prophylaxis with chloroquine. But this wasn't continued, and it's often thought that these prophylaxis campaigns were stopped because they became ineffective because drug resistance developed, and that isn't really the case. In the case of chloroquinization in Senegal, so it started in 1963, and it was very effective early on. But then it ran into trouble because the price went up, it became difficult to, the coverage wasn't very high, there were problems with supervising and delivering it in rural areas, and really just due to a lack of funding. And then in the late 70s there was a switch of emphasis to primary healthcare, and it was stopped, but it wasn't stopped as people think because of problems of drug resistance. Of course, that came later, but that wasn't the reason the prophylaxis stopped. So it's quite hard to tell from what we know about chloroquinization how really effective it was, because the kind of epidemiological studies that we would do now, those methods weren't really known then or used. And then the more scientific study of chemoprophylaxis in African children started in the late 1980s with a trial that was organised by Brian Greenwood over 5 years. And so this just shows you some of the results from that study. So what they did was children under 5 were allocated to receive prophylaxis every 2 weeks with Malaprim, which is dapsone and pyrimethamine, or a placebo. It wasn't randomized. Now this would be a randomized study, but even in the 1980s, those sort of methods were not widely used. So they were systematically allocated by compound. The first one getting placebo, the next one getting the active prophylaxis. There were health workers resident in the village who gave presumptive treatment with chloroquine if a child had a fever. And the project staff followed up a cohort of children to check for malaria by taking a blood film once a month. And they recorded all the deaths that occurred. And so these are the results, and there was a dramatic, as you might expect really, a dramatic benefit. So it was highly effective in preventing malaria, and it was effective also in reducing the number of child deaths that occurred. So there were very, very impressive results. And also, an important part of this study, which is that they were able to look at rebound. So children have prophylaxis for 5 years. It's targeting under 5s because that's the age group at risk of severe disease and death from malaria. And then once they pass their 5th birthday, it stops. And so what they did is then they looked what happens after that, and they compared children who'd had the prophylaxis for 5 years with children that had had the placebo for 5 years. And because the prophylaxis is very effective, it also prevents them acquiring immunity. So you see this kind of rebound. And what they saw was that if you had had prophylaxis for 5 years, after you stop, then there's a greater incidence of malaria than in children who did not have the prophylaxis. That wasn't the case for shorter periods of prophylaxis. But what was interesting is that they also looked at the mortality, and there didn't seem to be any evidence that there was a rebound effect in mortality. And so the implication of this was that we really need to protect children because they're vulnerable. They're more likely to have severe illness or to die from malaria than if they had malaria at an older age. So these were impressive results, but this approach then was kind of dropped. And it was dropped partly because of these concerns about rebound, partly because of concerns about safety of using drugs on a large scale in children, and also because at that time the use of insecticide-treated bed nets became much more widespread, and that seemed to offer a more attractive approach to malaria control. So it wasn't pursued. And these are some of the concerns that were raised about prophylaxis at the time: the cost and logistics of delivery, the safety, it would select for drug resistance and interfere with natural immunity. So some of these concerns have got more kind of substance to them than others. But these were some of the reasons why the thing wasn't pursued. And these are all of the questions that have had to be addressed in the more recent work leading up to this policy recommendation. And so, following on from this, intermittent preventive treatment was promoted. And this has the advantage that it allows malaria exposure in between treatments. So this is used now in pregnant women and in infants, and it takes advantage of existing contacts with the health system as well, so there isn't a problem about how to deliver it. However, this approach of intermittent treatment is not suitable really for children in areas of very seasonal malaria. So IPT-I, that's given when the child comes for vaccination, they're given a dose of anti-malarial, which gives them some prophylactic protection. Where malaria occurs in a short season, there's no guarantee that your vaccination date will come at the right time. So it's not such a useful approach. And also the burden of malaria is in older children, not just in infants. And so this seasonal chemoprophylaxis idea started with a study in Senegal of giving them intermittent treatment once a month, just during the transmission period. So this was done in Niaha, and so about 1,100 children were randomized, and they received sulfoxypyrimethamine and 1 dose of artesunate once a month, or a placebo. And then they were followed up, and the incidence of malaria was recorded. And so there was this very dramatic reduction, an 85% reduction in the incidence of malaria. So this kind of protective efficacy is unprecedented in malaria. It's a very difficult disease to control. So it was recognized that it would be important to see how this could become more widely used. They chose SP and 1 dose of artesunate because for this kind of, for prophylaxis, it would be good to have a treatment that you can give in 1 day that could then be supervised. There was, at the end of the transmission period, there was more resistance among children who were parasitemic. They were more likely to be carrying resistant parasites. So then several alternative drug combinations were considered, SP with 3 doses of artesunate and other artemisinin-containing combinations, and they were evaluated in a series of randomized trials looking at the tolerability and the efficacy and other criteria. And what this showed was that the most effective were combinations of 2 long-acting drugs, SP and amidiaquine and SP and piperacin. And these were more effective than the artemisinins, because of course the artemisinin disappears from the body very quickly and doesn't provide any prophylactic protection. So that was important because also it would allow the artemisinin combinations to be kept for treating clinical cases where their rapid action would be really useful. And we could use different drugs for prevention. Oh, and then of these two, this is the one that was chosen. In fact, empirical would probably be a more suitable combination, but it wasn't pursued because there was no licensed product. And it would have taken a number of years to have got that to a stage where it could have been used. Okay, so the other issue to consider was how to deliver this, because there's no mechanism for delivering an intervention to older children in rural areas once a month. And so three approaches were considered. One was through immunisation outreach clinics and asking mothers when they bring their infants for vaccination to also bring their older children. The other was mass campaigns, in the same way that vitamin A is delivered in many places, of going into the villages and organising the delivery through a mass campaign. And also through community-based management programmes where a health worker who's resident in the village delivers the prophylaxis. And so there are a number of studies looking at this, and I'm just going to tell you about two of them. So there were two approaches that were used. This one, which I'll tell you about, was a cluster randomised trial. And so groups of villages were randomised to have the prophylaxis delivered through the immunisation clinics or by village health workers. And then in Senegal, a different approach was taken. In Senegal, we arranged meetings with health staff and asked them what method they would choose to deliver this intervention. And there was a series of consultations, and they opted for a door-to-door approach, which was then piloted. Okay, so the first of those studies, then the unit of randomisation was the catchment population of each trekking clinic. And they were randomised to receive SNC from the trekking clinic or the health worker. You have to be careful with these studies because you're randomising, usually, they're large studies, but they're randomised by cluster. And the number of clusters is usually small. So we have to be very careful with the randomisation to make sure that it's balanced, and so we use constrained randomisation to ensure that. And then there was detection of malaria through the clinics and a survey at the end of the transmission season. So they were stratified, so the villages were, the groups of villages were divided into strata, and then within each stratum was constrained randomisation, so you repeat the randomisation many times and check for balance, and then you only accept a randomisation that's balanced. These are some of the materials that were produced so that the village health workers could understand clearly what they had to do. So this is showing the age of the child in terms of the number of months indicated by moons, or the number of rainy seasons that they've lived through. And then this is the dose that's supervised by the health worker, and then these are the doses that the mother has to give unsupervised at home of the two drugs. And so these are the results, which were quite clear. So what happened was that the delivery through the immunisation clinics worked well initially, but then the coverage fell off, and it was very difficult. The women didn't always bring their older children to the clinic, if they missed one day, there was no opportunity for a catch-up. Whereas in the village, if they missed one day, then the village health worker could treat them on another day. And so there was a big difference in the coverage and the percentage of children being treated, which was much higher in the village. The incidence of malaria was lower in the villages where the SNC was delivered by the health worker. And it was actually much cheaper, because to deliver through the EPI clinic, you've got to pay a trained nurse, and they're much more expensive than the village health workers were paid a small allowance each month. But so it was much more costly and less effective to deliver through the clinics. So this is a study comparing. There are really two active treatments. both of them were delivering SNC, and we were comparing the delivery method. So we would like to know that the interventions were really working compared to placebo or control. And we don't have that in this kind of, and this is a very common kind of design now, that you compare a new treatment with an active current treatment. And it's not ethical to have a placebo group who have nothing. So that's always a problem to know, well, are they really working? And this is one approach to that, which is a case control study. So the cases are clinic outpatients who have confirmed malaria. And the controls are children who were tested for malaria but were negative. And then you look from the record card and in the village registers to see, did they have SNC doses and the date of the dose. And then you also visit them at home to check for other confounding factors, for example, where they're using a insecticide-treated bed lamp. And so here we have the number of cases and controls that were enrolled, and this is the percentage that had an SMC dose in the last month. And you can see that the ones who did not have malaria, more of them had SMC. And so from this, and this is the case control idea, you can estimate the efficacy from a matched analysis. And so this gives us a figure of 87% for the protective efficacy of a dose of SMC. So this is a very important and quite underused technique, this case control study for measuring the efficacy of interventions. And I'm mentioning it now because as SMC is actually implemented, it'll be very important to monitor how well it's working. And this is really a tool that can be used. Well, I'll skip. I wasn't going to spend a lot of time. This is just to explain the logic of it. So in a normal prospective study, a randomized trial, you've got people who receive the intervention and controls. You follow them up and you record the incidence of malaria. And then you work out the protective efficacy from the incidence rate ratio, which is the number divided by the person time in each group. And you look at how much that's reduced. In a case control study, it's the other way around. You start with the cases and controls who don't have malaria, and then you look back to see whether they received the intervention. And from this you can infer the protective effect. And there's a bit of algebra which shows that the odds ratio for exposure, which in this case is having had SNC, is actually exactly equal to the rate ratio. So this is often not appreciated about case control studies. It's quite common for people to say that case control studies are useful for studying rare diseases because only then does the odds ratio approximately equal the risk ratio or the rate ratio. If you recruit your controls at the same time as the cases are picked up as they come to the clinic, and when you get this case, you go and get a control matched on time, then the odds ratio from the case control study is actually equal to the incidence rate ratio. So that's not widely appreciated, and these studies really should be much more widely used for evaluating interventions. Okay, so, all right, so I said I would say something about the policy process. And so there were two meetings which were quite important. This one was in 2008, and it was attended by researchers and heads of malaria control programs. Some of the funding bodies were there as well, and people from WHO were there. And the results that had been obtained were presented, and then there was a general discussion about did this tool have a role, or what were people's concerns. And so this is what people were concerned about. Drug safety, they really wanted comprehensive. People were always worried about using drugs on a large scale, and they wanted comprehensive data on the safety. Particularly they were bothered about sulfadoxine pyrimethamine, which is associated with these very severe skin conditions, Stevens-Johnson syndrome. So they were worried that there will be an increase in those. Rebound effects as well, which I mentioned earlier on. How could it be delivered, because there's no mechanism for delivery? And an important point was, is there really any benefit? So it seems to be very, very beneficial, but all the studies were done in populations that were not using insecticide-treated bed nets. So there is always this question, are you using the tools that you have available? Do you need a new tool, or do you need to just make sure people are using the old tools? The other things that were raised were that if there was to be a policy, it should be based on the evidence. So all the studies that have been done were in children under 5 and over 3 or 4 months of the year. And it could be that this would be useful in other age groups or in other areas, but we didn't have the evidence. And so they wanted that the policy should be based on the evidence, acknowledging that you might expand the policy later. And a very important thing was keeping prevention and treatment separate. So WHO, I think, they made a big thing out of making sure that treatment is only given for malaria if the person has had a positive diagnostic test. And without that, you're nowhere, because you don't know what the burden of disease is, you've got no surveillance. And so they made a big push for this, and they did not want to start introducing drugs for prevention. So they're then introducing drugs but without any testing, and that didn't fit with the kind of philosophy. And so they wanted to have a clear distinction between the use of drugs for prevention and the use of drugs for treatment. Up until this point, these interventions have been called IPT, intermittent preventive treatment in infants or in pregnancy. So what they said is, well, we don't want to use that term, let's think of another term. So seasonal malaria chemoprevention came in, which doesn't involve the word treatment, because treatment must come with diagnosis. And then they were bothered about the costs. What's it really going to cost? So then some studies were done to address some of these questions. This was to look at the question of bed nets. If children are all using nets, is there an added benefit? And this was done in Mali, in 2 sites, one in Mali and one in Burkina Faso. It's a large study with 6,000 children enrolled. And they all were given a long-lasting insecticide-treated net, and they were visited on a regular basis to make sure that they were using those nets. So the use of nets was extremely high throughout the study. They were randomized to have SNC with sulfadoxine-pyrimethamine and amidaquine once a month, or a placebo. And then, so here are the results, and this is the number of malaria cases with high parasitemia in the 2 groups. So same number of children, but you can see a big reduction in the number of cases. So this was a 75% of reduction, which is a very impressive efficacy. It was also quite surprising there was just so much malaria in children who were sleeping under what should be very effective bed nets. There was a reduction as well in severe malaria and in all-cause hospitalizations. Okay, and then there was a study in Senegal that was done, which was on a much larger scale, which was really to address the effectiveness, the practicality of can you deliver this on a large scale, and the safety and the costs. So we've been looking at this morning, because this same study site is now being used for a malaria elimination project, and there's a lot of interest in reasons why malaria is persisting in different areas. But this was done before that, and what I've shown here is the villages, and the boundaries are the health posts. So that each of these is the catchment area of a health post. And seasonal malaria chemoprevention was introduced into this area and evaluated in various ways. So the difficulty with this kind of study is that malaria transmission, malaria incidence varies a lot from one year to the next and from one place to another. And so this study design is a way around that. It's a step wedge design where you randomize communities to receive the intervention at different times. So we started in 9 health posts in the first year, and then gradually phased it in. And initially it was in children under 5, and then in the subsequent years, children up to 10 were included. And these are the methods that were used to evaluate the impact. So a demographic surveillance system was set up to record the mortality and to record all of the doses that were given. And this shows the number of children that were treated, the number of community health workers, and how many children each community health worker could treat in a month. And very high coverage could be achieved. So these are community health workers attached to the rural health posts and coordinated by the nurse, and then they go in a campaign once a month, in the same way that vitamin A is delivered. So in 54 health posts and 72 health huts, this is the reduction in malaria that was seen, about 56% reduction in the incidence of malaria. There was no effect on deaths, and we think that that's because at this time the transmission of malaria had gone down. There was also a lot of antibiotic use in this community, because along with the introduction of RDTs to diagnose malaria, if they're positive they're treated with anti-malarial, if they're negative they're given an antibiotic, so that can also have had an effect. Drug resistance, well, that was more common. So if you look at children who have parasitemia at the end of the transmission season, if they'd received SNC, then they were more likely to be carrying drug-resistant mutations associated with resistance to SD and to amidaquine. But the prevalence of those is much lower because the intervention is very effective in preventing parasitemia. So the net effect is that the prevalence of these resistant mutation, the prevalence of carriage of the resistant parasites is actually lower with the intervention. So I think this has been one of the big kind of stumbling blocks was to demonstrate that these drugs were safe when they're used on a large scale. And the difficulty of demonstrating this is it's easy to show something is safe if you're not looking very hard for the adverse events. And so a lot of effort went to make sure that if there were adverse events, then they would have been picked up. So these kind of charts were circulated to all of the health workers, and we sent text message reminders to all of the nurses just before each SNC round, reminding them to look out for adverse events, and then just afterwards to ask them if they'd seen any problems. And then these are some of the other methods that we used. So first of all, the mild adverse drug reactions. So these are children that reported to the clinic within 10 days with mild symptoms that seem to be related to the drugs. And you can see that it's a very small percentage of those who were treated came with some kind of problem. It was when they did come, it was vomiting and abdominal pain primarily, which we know is an effect of the amidaquine. But it seemed to decrease with successive months, and that's something that we've seen in all of these studies, that children seem to be becoming tolerized. And so there are more adverse events on the first round and less common on the subsequent ones. In terms of severe adverse reactions, so there were no serious adverse events that were attributable to the drugs. There were severe skin reactions that were seen, but these children had not received SNC. So this was really a very important result, which came from this very large-scale pilot with very careful surveillance for adverse events, and this was really necessary. I think, first of all, it showed that it could be delivered on a large scale and that it was safe. And those have been very key bits of evidence that led to this new policy. This is just showing you the cost. So the big part of the cost of delivering it is the cost of the drugs. and the cost of actually delivering it in the community, and so the payments to the health workers. In this study, there were also some research costs, which it's difficult to kind of exclude those from the economic analysis, because they may have contributed to the overall level of coverage, but we can consider these costs either with or without these. But including them, then the cost per month per child was about 50 cents. So that would seem to be an affordable or a reasonable cost, bearing in mind how effective the intervention is. Okay, so I mentioned that there was a desire to limit the policy to the areas where there was evidence. And so that is children under 5 living in areas with highly seasonal transmission, where most of the malaria could be prevented by prophylaxis for 3 or 4 months. And so this was a mapping exercise to see how many children fit into that category. And this is really the band where malaria is highly seasonal, there's a high burden of disease, and living in this area there's about 25 million children under 5. Also, what is interesting is that it coincides with the areas where these drugs are still effective. So in East Africa there's more resistance to both drugs, but where SNC might be used, the resistance is low. This also showed that in this part of South East Africa, malaria is also seasonal. So this tool could be used in that part of Africa as well, but different drugs would be needed there because there is a lot of resistance to OSP. So then there was a 2011, there was a technical expert group convened by WHO to review all the evidence. And that was quite an interesting process to see what issues they thought were important and what they thought were not important. They were very keen on the idea that there should be complete protection. They didn't like the idea of intermittent treatment. They thought that the aim should be to provide effective prophylaxis. They weren't concerned too much about drug resistance because they said that effective prophylaxis does not select for drug resistance. Ineffective prophylaxis is the problem. They were not concerned really with rebound. They were persuaded by this argument that young children are vulnerable and we should do our best to protect them, even if to some extent that delays illness, it won't be as severe. And it was important to look very carefully at age-based dosing to make sure that the simple dosing regimen was used. And they had a slightly different take on this, which was, of course, there's always a balance between efficacy and tolerability. And they were slightly more towards higher efficacy at the price of tolerability. So a revised dosing scheme was drawn up. And then there was some further analyses really of existing data that were asked for. They wanted a systematic review of all of the studies. They wanted to know more about the effect on mortality, and we weren't really able to give very good answers to some of these things, and it was recognised that they would have to be addressed later in phase 4 studies after the intervention is introduced. Okay. Yeah, so then the policy came out last year, so March last year, and shortly after that an implementation guide was produced by WHO. And so what I've tried to do here is to map where, and this may have changed just recently, so this was done a few months ago. These are countries which have now included SMC in their country's strategic plan for malaria control. And these are countries where they have not done so, but SMC could be useful. And starting this year, SMC will be implemented in southern Senegal by the National Malaria Control Programme, and it's being implemented in Mali by MSF, and MSF will also this year implement it in Chad and Niger, and there's a pilot project in the north of Nigeria where SNT is going to be piloted. Yeah, so I said I'd just say something about what are these sort of opportunities for further research. And so it will be important to look at a number of things when SNC is introduced. There'll be the kind of routine monitoring to look at the delivery, and if it's not being delivered effectively, what are the reasons and so on. It'll be important to monitor drug resistance in a coordinated way, and to be alert to any spread of drug resistance and to think what to do about that. It's also important to look at the effectiveness, and we think there'll be a reduction in child deaths, but there isn't solid evidence about that now. And so it'd be important to do these kind of effectiveness studies to really document what's the impact, using surveys and case control studies. Yeah, okay, so just in conclusion. So this has been, I think this is been quite a rapid process. So the first trial was done really in 2002. There was a trial in Senegal and another one in Mali at that time, which both showed that this was a promising approach. And so it's taken, 10, 11 years or so for it to be actually implemented. And it's useful just to see why that has been a fairly rapid progress. One is it's been really done in partnership with scientists in the different countries working together of where SNT might be implemented. And they've maintained contact throughout with policymakers in their ministries of health, in their malaria control programs, and also in WHO. And that meant when there were questions being raised, they could be addressed quickly. An implementation guide was published quickly, shortly after the recommendation was produced. So that was important because that's the basis for countries developing their own strategic plans. And then there was a series of meetings to help them to develop those. And in terms of further research, then it's going to be important not just to look at drug resistance, but to have a coordinated approach to monitoring what the impact of this is on child health or mortality and longer term outcomes. So I've just listed, there's a long list of people who contributed to all of this work, so I'm sure I've left lots of people out. That's the trouble when you put these lists up. And a lot of it was funded by the Gates Foundation. Okay, that's all I've got to say on it, but anyway, ready for any questions about it. Thanks very much.
Il y a des questions?
Oh yeah, yeah.
You said that there is one way to have
this one.
Yes.
Yeah.
What is the conditions of the two methods to use?
Yeah. Sorry. Yeah. Well, there's two. The key thing really is that when you recruit your cases, you do that when they're diagnosed. So rather than wait to the end and look and see who had the illness, you have active surveillance that picks up the case when it occurs, like malaria being diagnosed in clinics. And then at that time, perhaps within a week or so of that case being detected, you go and recruit your control, who is someone who is free of the disease at that time. And then so you're matching your cases and controls on time. So they've been exposed for the same amount of person time. And that's the key thing in this argument that then makes it equivalent.
The rationale is because the incidence of malaria is low. That's the level we use case control study to estimate the risk like study. Or if your intervention is not effective, it's possible to do the case control study to do this estimation.
So there's no requirement for the incidence to be low. So that is a kind of, that's what people often say about case control studies, but it's not true. When you use this kind of design of picking up cases when they occur and the controls at the same time, it's not relevant whether it's a rare disease or a common one. The thing about rare diseases is that they're very difficult to study with a cohort because you need to have a huge cohort. So case control studies are quite good for rare diseases for that reason. But there's no reason you can't use them for common diseases. That's a sort of superstition.
I mean, mainly all the evidence-based story has been based on the fact that you randomized before.
Yeah.
So you're saying that it's wrong.
No, but you should randomize, and that's the gold standard. And of course, the problem with case control studies can be that there's some confounding there because there may be some other factors that are different between the cases and controls, and you don't have randomization to prevent that. So randomized studies are the gold standard, but they're sometimes just not possible. And once an intervention's been rolled out, you can't randomize any longer.
Well, in randomization, also people don't want to see that there is a, well, I mean, the whole problem is to avoid bias. You agree? So there is bias when you look at case control study because those that take the products are different from those that don't take the products. But there is a problem with randomization as well. Because in randomization, you tell the people that there is half chance where there is nothing really. So the adherence, the compliance to the real thing is completely different than people believe that what they take is wrong. So there is a huge bias in one mind that nobody wants to see because people are just, they're not talking to the people. But you're talking to the people, and worse than if you talk, which I do for all the diseases that I've been working, I make the dosage. And I can make you a deal. If you give the patient a treatment saying that it works in all cases, it is compliance. And look at the compliance of those that have been randomized. Maybe you have a huge surprise. I think that half of the people don't take it.
Yeah, I mean it's essential to try and document the compliance.
Yeah, but or do you comment? Do you make dosage out of it?
Do you mean?
Do you dose that in the blood or in the urine for the compliance?
That's been done in some of the studies. Is to actually look at, but that's not possible on a large scale. But you check. I mean, you can check for leftover medication. You can ask about. You can go visit them afterwards and talk to them about whether they had any problems giving these tablets. So you can get some kind of idea about adherence.
My goodness, people lie terribly. And if you, the only thing is that if you look at it, I mean, this is a thing, we have been involved in several studies where we look at the first cause of failure of the treatment that should be efficient was that people were not taking the pills. This is most, that's the same with HIV, so one of the very first causes that people don't take it, and specifically, and when you remember this story of randomizing of the very first Concord study, you remember this? What they do is that they will randomize, and outside, this is where the great people from San Francisco, outside they mix up and exchange to make that everybody get a little bit of this. And then you make the study and look what's happening. In fact, they were all mixing this. So, I mean, it's very, I think it's one more example of very scientific belief that we apply yes or no, going to people do what they want.
I think isn't this why people like this intention to treat principle, because you need to look at compliance. If you randomise and look at the outcome, and if you see a benefit, it's working in some way, even if it's not such good compliance. It's when you restrict your analysis to compliance, then you have all these. I quite agree that the compliance are intrinsically different and so on.
No, I'm not saying that this is not useful. I think that we don't want to be naive about it. So one to think there is gap, that there is gap everywhere. I mean, there is no one goal saying that you don't get the outcome.
May I ask quick two questions? You mentioned in your introduction that the program was stopped because the price of the drug went up. So how can the price of a drug go up these days? Really, is it more costly to manufacture? I'm not sure I understand what the price of a drug go up.
I don't know. So that is what so in the accounts of the chloroquinization campaigns in the 60s and 70s, what they say, and they gave the price per tablet, which I can't quite remember now, but it doubled. So what the reason for the price of chloroquine doubling in that period was, I don't know. But the other costs with the campaign is all the supervision, and that's labour cost, which I guess went up.
Absolutely, yeah. That could have been that. And given that children can die from a particular disease, is this ethical to give them treatment?
Oh, it's prevention.
Prevention, prevention.
Yeah, no, it's not. No, that's a problem. So only the early studies were placebo controlled, and a lot of the later studies did not have a control group for that reason. Yeah. So the drug regimen studies, for example, didn't have a placebo group.
I just thought about you about the problem because I know the relatively few events occur because access works to the majority of the cases. And I was did you thought about a way to adjust the bias, which is called a propensity scores. It's a method that has been used in monitoring adverse events, rare adverse events in drugs. Could be used and better only adjusting the matching on the length of the exposure to the drug.
Yeah, I guess that would be used. I suppose the thing would be if we have good propensity scores from the area, if we know enough about.
Because there must be different ideas according to the local location.
Yeah.
The village and so on. This would be taken into account.
That's true. That's true. Yeah. So it'd be their age, whether they're using a name. I'm not sure what other factors. But things might vary a lot of place.
Allez, une question. One more.
I want to ask if the SMC program and also if it can have effect as like creating community immunity on the general population, and has that possibility been looked at?
Yeah, that's a very good question. Yeah, so that was not really. I think it was always thought that it would not have any effect on transmission, because you're just treating a small age group of children under 5, and it was thought because the gametocyte carriage, the prevalence of gametocyte carriage will be quite high in older age groups, and effective control in under 5s was thought would not have any effect on transmission. And that was sort of part of the argument about drug resistance as well, which even if there was selection for drug resistance, then there wouldn't be a lot of onward transmission for kind of similar reason. But that may not be. So in Senegal what they're doing is they've gone up to 10 years because there's quite a high burden of more severe illness in that older age group. And they're going to do MSD up to 10 years. And so it's possible then that this might start to have some sort of effect on transmission. I guess I think it probably won't, but and particularly where this is going to be used in very high transmission settings, where we know it's very difficult to reduce transmission in those situations. But it's something that there doesn't seem to be any evidence for it so far, but we should probably look for it in these phase 4 studies.
Okay. Thanks a lot again.